exercise, lifestyle changes. As you were saying, obesity is one of the risk factors, as we know. So I was always wondering that promoting lifestyle changes and awareness can help.
Sorry, yeah, you.
Okay, you didn't get my.
No, I didn't. You want to advise women to exercise?
Yes.
I advise everyone to exercise.
Exercise with also promoting this more active living style than having sedentary lifestyle, which by itself is a risk factor. So
I think we need the chapter to organize for us a meeting on well women, how to maintain well women health. So exercise and healthy food and everything is good because you reduce all risk of whatever.
I'm sure it's going to be a great question. It's not a question, it's just my
advice. Yes. Well, you see, as a healthcare provider, you have responsibility to do that. To be honest, as a healthcare provider, you have a responsibility for the society to ensure that to really instruct them once and again how to maintain health.
Especially the one you're using oral contraceptive pills.
Well, everyone.
Could be part of education.
Everyone. But this is to come for a contraception counseling. It's a very excellent opportunity because she's not ill, she's not sick.
Please keep quiet in the back, please. We cannot hear the questions and the answers. Please,
Professor Saad, thank you for your last presentation. One risk factor which I don't know whether you should consider or not is the thrombophilia risk, which is probably different between different populations. And I think it might go with the one issue with the duration. There's some special populations will be at risk. But there is a difference in the thrombophilia between different populations. Should that be considered also among the way of assessment the thrombophilia risk different in Caucasian from other populations?
Yeah, very good. The question is thrombophilia. Thrombophilia is, as far as I know, in the Caucasian population, it's present at a rate, if I'm not mistaken, I don't think I'm mistaken because I have recently looked at it, between 2 to 10% in asymptomatic population. Now, of course, there is no recommendation that you screen people before you prescribe contraception for thrombophilia, but you screen history. If they have previous history of thrombosis, if they are known family history of one of the high risk thrombophilia, there is a low risk and high risk. The high risk thrombophilia, if one of the close relatives had first degree relative have a deep vena thrombosis, then all will trigger you to screen from thrombophilia. Otherwise, you don't really screen from thrombophilia. And I'm not aware of, for example, thrombophilia among Kenya or in our part.
That was my point. My point is that almost all of these studies were done on Caucasian population.
Yes.
Who has a higher risk of thrombophilia. So it's probably that, if you're going to use the same medication in other populations, you might not run the same risk.
Maybe true. I have no idea.
next question.
Yes, Professor, thank you for your nice presentation. I have a case who's presented.
With the laparoscopy, we can pose the diagnosis and do the treatment better than to do MRI and aspiration and all.
So you diagnose by laparoscopy? Yes, you can diagnose by laparoscopy. MRI is non-invasive.
I have MRI is the radiation.
But I am going to terminate any and it is safe and predictive.
No, I have a follow-up on this question, Dr. Saeed. So what is next? This is a rudimentary hole that you successfully evacuated and it is still there. And the same thing may happen again.
Yeah.
Wouldn't you allow this patient to go for a laparoscopic semi-hysterectomy or hornectomy?
We do nothing. Prognosis is very good because recurrence is extremely rare. It is 1 per 100,000 pregnant. So I leave this hole as long as it is asymptomatic.
But also, pregnancy in a horn, I mean, a rudimentary horn, is very, very extremely rare.
Yes.
It happens in her case.
You
I'm really worried about this patient next time when she comes with the testing.
You cannot have two occasions of two extreme cases.
What's the harm of doing a laparoscopic hornectomy?
No harm. But if this patient is going to do laparoscopy or laparotomy later for any reason, we can take the horn out.
Sure.
Maybe next year we'll have a presentation of recurrent two-hole pregnancy.
Any other question?
Thank you very much. I'd like to thank you, Professor Nasser, for your elegant presentation. I have a question. Now, after you clarify the message that drospirenol is not associated with a more VTE risk in comparison to the other COCs. So if we have another preparation like YAS, which is a 20 microgram ethylene estradiol, so we have a less concentration, which one you're going to prefer, Yasmin or YAS?
An evidence-based?
Yes.
I don't have an evidence-based.
Okay, thank you.
Any other question? One question in the back, please. Put the microphone.
Describe the recurrence of ectopic pregnancy is very rare. What about the risk of dysmenorrhea? It's functioning, non-communicating rudimentary hernia.
I think there is no relation between the rudimentary horn and dysmenorrhea.
One question there, please. المايك لو سمحت. كيف حالك يا دكتور؟ هنا.
Actually, my question for Dr. Rim, in acute abdomen, if we diagnose perforated appendix in a pregnant patient in the third trimester, now which is safer to go for conservative management and internal appendectomy after delivery, let's say, or if we go for immediate surgery?
Right. Saeed, I have another question for you. Why didn't you leave it? This is a uterus with good uterine wall. I mean, let the pregnancy carry on without evacuating or emptying the whole pregnancy.
Like to keep pregnancy in non-communication rudimentary horn or rupture.
What is the rate of rupture?
It's 100% going to rupture. If you leave this pregnancy, it's going to rupture 100%.
At what gestational age? At what gestational age rupture?
What?
At what gestational age?
At what
Yeah,
stage?
usually it is from 16 weeks to 24 weeks. This is usually.
Early rupture.
Early rupture at 16, late rupture at 24.
This question. What would you do? What would you if you get the case like this?
I watch it.
You will not remove it.
Yeah. Why? I mean, a viral pregnancy, good uterine wall thickness that will give you the impression this will extend just like any other uterus. Of course, you get the baby by cesarean section.
No. I will wait for the spontaneous onset.
Any more questions?